I'm Joe Graydon.
And I'm Terry Graydon. Welcome to this podcast of the People's Pharmacy.
You can find previous podcasts and more information on a range of health topics at peoplespharmacy.com. Millions of people who have had COVID-19 continue to suffer debilitating symptoms for months. They're called long haulers. This is the People's Pharmacy with Terry and Joe Graydon.
Many people who get through the initial COVID infection end up with overwhelming fatigue, shortness of breath, brain fog, or dizziness on standing. What is causing such incapacitating symptoms?
Many clinics now offer long COVID patients a variety of treatments for the broad range of symptoms they suffer. The director of the Recover Clinic at the Cleveland Clinic describes their program.
A research group thinks it's found the cause and a potential treatment.
Coming up on the People's Pharmacy, finding ways to manage long COVID.
In the People's Pharmacy health headlines, an outbreak in a Texas prison reveals how contagious the Delta variant of COVID-19 is, even for people who are vaccinated. There were 233 prisoners in this part of the facility. 79% of them, 185 individuals, were fully vaccinated. This summer, 3/4 of the prison population caught COVID. 39 out of 42 unvaccinated prisoners were infected. That's 93%. On the other hand, 129 out of 185 fully vaccinated people came down with the virus. That's 70%. Of the 172 individuals who were infected, 4 needed to be hospitalized. 3 of these were unvaccinated, including the one who died. The Moderna vaccination appeared to provide better protection than the Pfizer-BioNTech vaccine. One of the most important lessons from this outbreak is that fully vaccinated people are still quite susceptible to infection with the Delta variant. While vaccination helps protect people from hospitalization and death, it's not enough to prevent infection. The CDC is not tracking breakthrough infections unless they result in hospitalization. The data from the Texas prison demonstrate that vaccinated people are still quite vulnerable to infection from SARS-CoV-2. The implications of this report suggest that early testing, isolation of infected individuals, and masking are important additions to vaccination.
A study of men with high-risk prostate cancer found that adding a drug to conventional treatment reduces the likelihood of metastases and improves the chance of survival. The research, conducted in the UK, randomly assigned 988 men to conventional hormone suppression plus radiation. Another 986 men were assigned to take abiraterone in addition to radiation and anti-androgen hormone treatment. 6 years later, 82% of the men on the triple treatment regimen had no metastases. Those on standard treatment did not do quite so well. About 69% of them did not have cancer beyond the prostate. Abiraterone also improved survival. After 6 years, 86% of the men in that treatment group were still alive. That's significantly more than the 77% of the control group who survived 6 years. Prostate cancer thrives on testosterone, which is why the conventional treatment suppresses this hormone. Abiraterone, also known by the brand name Zytiga, prevents the cancer cells from creating their own testosterone. The lead author was quoted, "Based on these results, all men with high-risk, non-metastatic prostate cancer should be considered for 2 years of abiraterone."
Many cardiologists have added coronary artery calcification (CAC) scores to the risk factors they use to determine if someone has coronary artery disease. A score over 100 is considered a trigger for statin therapy. New research from Korea has turned up an interesting paradox. Over 25,000 adults were included in the study. They were scanned at least twice between 2011 and 2017. Their weight, cholesterol, and blood pressure were measured, and they answered questions about their family history and physical activity. Volunteers who exercised regularly were most likely to have high CAC scores. In addition, their scores increased more rapidly over the course of the study. The doctors don't know what to make of the accelerated progression of coronary artery calcification in vigorous exercisers. They note, however, that physical activity is good for the cardiovascular system.
Another interesting paradox involves statins to lower cholesterol. A study published in JAMA Cardiology showed that people taking statins had larger increases of high-density calcium plaque compared with plaques in patients not treated with statins. A question that cardiologists may need to address is why both intense exercise and statin therapy appear to accelerate calcified plaque progression. And that's the health news from the People's Pharmacy this week. Welcome to the People's Pharmacy. I'm Joe Graydon.
And I'm Terry Graydon. The COVID-19 pandemic has disrupted hundreds of millions of lives. At last count, 230 million people have contracted the virus worldwide. Nearly 5 million have died. Even when COVID-19 does finally fade, there will be millions of people who still have to deal with its consequences every day. Some proportion of those who come down with COVID don't fully recover. Months later, they're still troubled with symptoms such as fatigue, shortness of breath, or brain fog.
These individuals often refer to themselves as long haulers. They've brought the problem of long COVID to the attention of the medical community.
Initially, some doctors were skeptical that people were really suffering from long-term consequences of a COVID infection. But now clinics are springing up all over the country to address the ongoing problems people with long COVID are facing.
To learn more about this growing problem, we turn to Dr. Kristen England. She's an infectious disease specialist who leads the Cleveland Clinic's Recover Clinic for long COVID patients who are suffering with lingering symptoms. Dr. England is board certified in internal medicine with a subspecialty certification in infectious diseases by the American Board of Internal Medicine.
Welcome to the People's Pharmacy, Dr. Kristen England.
Thank you so much, both Joe and Terry, for inviting me on to talk about this really important topic.
Dr. England, I think by now a lot of people are very too familiar with COVID-19, but they kind of recognize, okay, most people get over it. That is to say, the vast majority recover. It may take a week or two, maybe as many as 3 or 4 weeks, but there are some people who do not get over it over a couple of weeks or a month or two. And we've got all kinds of names for this condition. It's been called long haulers, post-COVID syndrome. You know better than we do what it's called. Could you give us a quick overview of the symptoms, the most common ones, the most debilitating ones, and the ones that many of our listeners have never heard of?
Oh, sure. As you mentioned, this is a disease that has so many different names to it. And I think it was initially called post-COVID. And when you talk to patients, their biggest complaint was, this is not post anything. We're in the midst of it. So that's how the term long haulers came about. And that's been shortened down to long COVID. But if you look in the medical literature, they're going to still refer to it as post-acute sequelae of SARS-CoV-2 or PASC. So all of these terms really mean the same thing, though. These are patients who generally 4 weeks after they've been diagnosed with COVID still have persisting symptoms. And a lot of those symptoms, the predominant symptom that patients have is really fatigue. This is just the kind of fatigue that can vary from not being able to really go on the same run that you used to going on to literally not being able to get off the couch, unable to go to work, unable to care for their children and their loved ones. So fatigue is the number one complaint that we hear about.
Well, I wonder if you could go into a few of the others, because I have to be honest, they have somewhat surprised me. We're talking about things that we don't normally associate with a viral infection. So, well, maybe headaches. But then there's this thing called brain fog.
Yeah.
And then there's this weird thing called hair loss. I mean, why would a virus cause hair loss as a long COVID symptom?
Yeah, it is amazing. In some places, you can see up to 200 different symptoms listed as being related to long COVID. So it's difficult, and everybody is going to experience long COVID a little bit differently. So where some people may experience, as you mentioned, hair loss or persistent loss of the sense of smell and taste, or GI issues like diarrhea or just persistent indigestion. Everybody's body is affected quite differently from this virus, and it's a very difficult virus because unlike some infections that really mainly affect the lung, we think of influenza, respiratory syncytial virus as mainly affecting the lung, or hepatitis is a virus that really mainly affects the liver. This virus really impacts almost every single organ in our bodies. And that's where you get the complexity of symptoms that people have with either the acute syndrome and also with these long COVID symptoms. So my goodness. So the brain fog is certainly something that our neuropsych folks have been looking into, and patients really complain mostly about just kind of these higher level cognitive functioning. So they're having difficulty with, completing, balancing their checkbook, kind of more higher level cognitive issues, and somewhat also with memory. So these can be very debilitating when people are trying to get back into their workforce or the work that they were doing previously. So we've got brain fog, as I mentioned, the sense of smell and taste, these kind of rashes that may either persist or just are fleeting, a lot of muscle aches, joint aches that you can see also with this. Probably one of the more next in line to fatigue and brain fog. One of the other most common symptoms that people are having are this sense of shortness of breath or even just breathlessness, where they may be able to complete an athletic task, go out for a good long walk, but there's this persistent sense that they can't get that deep breath in. So those are some of the most disconcerting. If you don't feel like you're getting your breath in or gasping for breath, I mean, that's pretty frightening.
Dr. England, I'm wondering just how common is this long, persistent problem of symptoms that last a long time after we imagine the infection should have cleared up?
Yeah. So even the definition of long COVID is not 100% ironed out. Many places use 4 weeks. So after you've gotten a diagnosis of COVID, if symptoms persist 4 weeks or longer, you can be considered long COVID. Over in the United Kingdom, between 4 and 12 weeks, they'll say that you just have a persistent COVID syndrome, and then long COVID after 12 weeks. So even amongst, those who are trying to define this, there's no clear definition, but at least my clinic, here at the Cleveland Clinic, we are defining it as 4 weeks beyond a positive PCR test for COVID. So, when you talk about the number of people who are developing this, let's go with, say, the 4-week definition. We're talking anywhere from, some reports have said as low as 10%. Some reports are saying as high as 50 to 60% of patients. But I think most of us fall somewhere between, say, 10 and 30% of patients. But when you look at those numbers, it doesn't sound like an awful lot. But my goodness, when you look at the numbers of COVID cases that we have, as of today, we have almost 218 million cases of COVID worldwide. So if you only assume 10% of those patients have long COVID, that's still 21 million people across the world that are going to be dealing with long COVID symptoms. In our country alone, we're almost at 40 million cases. So that's 4 million long COVID cases that we're going to be dealing with here in the United States. So the numbers no matter what percentage you use, are significant. And depending upon how debilitated people are, this is going to have a significant impact on healthcare systems, on the workforce if people are unable to return back to their workforce. This is not something that we can ignore as a real clinical second pandemic.
Well, I'd really like to ask you about that specifically, Dr. England, because early on, while we were still learning a lot about this pandemic, and we still are, unfortunately, learning a lot, this virus still has tricks to teach us. But people who were suffering these persistent symptoms would go to their doctors and be told that it was psychosomatic. So are physicians in general now taking this situation more seriously?
I do think so. I do think that many physicians are now truly starting to recognize this as a real medical entity. I appreciate the fact, though, that for some patients they've encountered providers who have not taken them as seriously. I do find that one of the things that patients will comment most when they come to our clinic is that they feel validated. Somebody is finally not only listening to what their symptoms are, but recording them and trying to study them and learn about them and get them into the care that they need. It is tremendously difficult. I can only imagine to have also symptoms that can be very difficult to quantify. When you think about it, I'm fatigued. Well, what is causing that fatigue? Are you depressed because you've been homebound because of COVID? Are you depressed for a number of different reasons? And is that what's causing your fatigue? Or is it something else? So I think when many patients had these initial complaints initially, they were written off as being told, oh, you're just depressed. That's what we're finding is that's not the case. And it's going to take more time for all of our providers to really be able to appreciate this as a true clinical syndrome. But it has certainly gained the acknowledgement from the World Health Organization, from the Centers for Disease Control, from the National Institute of Health. Worldwide, people and providers are starting to really come to grips with what this is.
You're listening to Dr. Kristen England. She leads the Cleveland Clinic's Recover Clinic for long COVID patients with lingering symptoms. Dr. England specializes in internal medicine and infectious diseases.
After the break, find out who's susceptible to long COVID.
Is there any way to predict who will continue to have symptoms months after an infection?
Why is the range of symptoms so broad?
Are people with long COVID actively transmitting the virus? In other words, are they contagious while they have symptoms?
People with long COVID want to know about vaccinations. How did they respond?
What treatments does Dr. England's Recover Clinic utilize?
We'll also get her advice for people who suspect they may be long haulers.
You're listening to The People's Pharmacy with Joe and Terry Graydon.
The People's Pharmacy podcast is sponsored in part by Kaya Biotics. KAYA Biotics offers the first probiotics which are both certified organic and hypoallergenic.
All probiotics are produced in Germany under laboratory conditions with high-quality ingredients and under strict regulatory oversight.
The 3 available formulas are created for very specific purposes, such as strengthening the immune system, fighting yeast infections, and helping with weight loss.
To learn more about Kaya Biotics probiotics and the important topic of gut health, you can visit their website, KayaBiotics.com. That's KAYA Biotics.com. Use the discount code PEOPLE for $10 off your first purchase. Welcome back to the People's Pharmacy. I'm Terry Graydon.
And I'm Joe Graydon.
The People's Pharmacy is brought to you in part by Kaya Biotics, organic probiotic products made in Germany. KAYA Biotics.com. debilitating.com.
Also by CocoVia, now offering its cardio health powder with 500 milligrams of cocoflavanols. More information at cocovia.com.
Our topic today is long COVID, troublesome symptoms that may persist for many months after a person is infected with SARS-CoV-2. Medical professionals are starting to recognize this as a syndrome that deserves attention. How can patients find ways to manage long COVID?
There's a huge range of symptoms associated with post-acute sequelae of COVID-19, PASC. Some people suffer from loss of taste and brain fog, while others have trouble breathing, overwhelming fatigue, heart palpitations, and depression.
We're talking with Dr. Kristen England. She leads the Cleveland Clinic's Recover Clinic for long COVID patients with lingering symptoms. She has a long history working with disenfranchised and overlooked patient populations.
Dr. England, you've been quoted as saying studies suggest that anyone who contracts the virus is at risk for long-term symptoms. And yet, I suspect that a lot of people still think of older, sicker people as being most vulnerable to COVID-19. I'm curious, who can get this long hauler problem, this long COVID syndrome?
Well, I think what we're finding over the last 6 months is that the people who are getting acute COVID, the demographics for them is also changing. Yes, initially for COVID, we were seeing patients who were older, who were more debilitated, who had underlying diseases such as diabetes, obesity, emphysema. But over the last number of months, we've been seeing with the Delta variant, folks that are younger, less likely to have these comorbid complications. And unfortunately, we're now starting to see more children getting affected by the acute COVID. So I think we've also seen some of the changes in the demographics of our long COVID patients as well. When I looked at our first 924 patients that have come through our Cleveland Clinic Recover Clinic, the average age that we're seeing there is 49.7 years. So it's kind of middle-aged. We're not talking about our eldest. We are looking at our youngest patient is 18. Although I've heard of patients in the 15, 16 range, but we were only taking adults, so 18 and older. And our oldest patient was 87. So we've got a big mix of age ranges. And we're also seeing a fair split. I will say we are about 73% women. Some other studies coming out of China are looking at about a fairly even split with 53% men. But, I would say predominantly I've heard most reports with a little bit more swaying toward the female population with having more of the post-COVID.
Is there any way to tell who is most likely to develop post-COVID problems if they do come down with the infection?
Oh gosh, that's a great question, and I wish we could. That's one of the things that we're starting to look at is who really is most at risk for this. And it would have seemed that if you were hospitalized, that you were more likely to have persistent symptoms, and that's really not the case. So what I'm finding is that coming into our clinic, and it's true across most studies, is that only about a third of patients who are presenting with persistent symptoms have been hospitalized. So even if you had a mild or a moderate case, or sometimes even no symptoms at all, but just happened to test positive, you can still develop symptoms or have persisting symptoms 1, 3, 6 months later. So it's not just the sickest of the sick who have the persistent symptoms. It can be just about anyone.
I've been really puzzled why this virus can cause such a diverse range of symptoms in this post-COVID syndrome. For example, why hair loss? Why loss of taste or inability to smell things? Why tinnitus, ringing in the ears? It seems like this virus is affecting the central nervous system, which would be causing the brain fog, but it's also affecting the heart it's also affecting the joints. It seems like, as you said, it's affecting every organ in the body.
Yeah, well, our bodies, you're absolutely right. Such a diverse range of symptoms. This virus uses this ACE2 receptor to be able to really enter the cells, and these receptors are on so many different organs within our body, whether it's the GI tract or the lungs or on the heart. Frankly, some on the cells in our nasal passages that called the olfactory cells that allow us to smell. They can all be significantly impacted. And again, with all of the variety of symptoms that people can have, again, why are people getting tinnitus with that? It's probably affecting some of the cells within the inner ear that, that will then persist and have the ringing symptoms in the ears. But not everybody's going to have tinnitus. Not everybody is going to have lost their sense of smell or taste or have diarrhea, but you can present with any one of those symptoms and still have long COVID. It's not just the people who are presenting with the cough and shortness of breath that we typically relate to an acute COVID syndrome.
Do we have any idea why some people present with one type of symptom or long COVID at all, and some don't?
We don't. We have some early studies that are coming out. One of some of my colleagues here at the Cleveland Clinic looked at survivors of COVID who had moderate or severe obesity and found that they were at greater risk than those who were not obese for having long-term consequences of the disease. So there may be some of the risk factors that put people at risk for COVID in the first place that are also putting them at risk for long COVID. But that's where the studies are looking at right now, is really trying to figure out who and what underlying symptoms that they had could be contributing to this. In our clinic, we're also finding that folks who have underlying asthma, about 25% of my patients in the long COVID clinic have asthma. Hypertension, about 23% of the patients had underlying hypertension. So are those contributing, or is that just simply a marker of we have all of that in the population in general? Is it even something that makes them more at risk? We don't know. And I think we're going to have to learn more looking at this population of long COVID patients before we can start to make any clear connections with that.
Right. Now, Dr. Englund, what about contagion? I think there are people who are a little worried about getting close to someone who has long COVID syndrome because they think, well, maybe they're still going to pass it to me. Is the virus long gone, or is it still possible it's lingering?
Yeah. Well, the virus is long gone at that point in time. So there are questions about what actually causes long COVID, and is it still fragments of the virus that are present, not infectious fragment, but fragments that then the body is still reacting to, or is this just the inflammatory response that the body has had to the virus? Again, the virus is gone, but you still have this inflammatory response. But nobody should be worried about getting infected from somebody with long COVID. This is certainly not something that they can pass to other people. It's just simply their own body's response to a previous infection that they had.
Do we have any data on how people respond to vaccination? Presumably, people who have long COVID had COVID to start with, and therefore would be eligible to be vaccinated once they're recovered. But how do the persistent symptoms respond?
And I've wondered if, because we've heard sort of anecdotal reports that people who get vaccinated sometimes get better after a vaccination. That is to say, their long COVID symptoms begin to fade.
Oh, I've heard those anecdotes as well. And unfortunately, it's not been found to be more than just anecdotal reports. I hope it's true. I wish that it could be true, because that would certainly be one great way that we could offer our patients some relief from their symptoms. But doesn't seem to be across the board that if patients get vaccinated, frankly, I think some of our patients express concern about getting vaccinated, that, is it going to make their symptoms worse? And I've not seen that. I've certainly not seen that patients' symptoms get worse. I would say the majority of patients don't notice any difference. And for those who do notice some improvement, fantastic. I wish them all the best, but I wish that was the case. But I do certainly encourage anyone, period, to get vaccinated. But certainly if you have long COVID, go ahead and get vaccinated as well, because it's certainly important. You don't want to get infected with COVID again.
Now, Dr. England, you're running a clinic called the Recover Clinic for people who are suffering from these persistent symptoms. Can you tell us what treatments your clinicians are using and finding helpful?
So what we've been doing is bringing in patients who are at least 28 days past their COVID diagnosis. And I will tell you, I feel I struggled with this off the bat, because one of the requirements to get into the clinic is to have a positive PCR test that's been documented. And a lot of that was because I really wanted to make sure that we were not mixing apples and oranges. When we looked at these patients, I wanted to make sure that we were dealing with COVID and not complications from other disease processes, whether it be another virus or something else that has these patients having long-term persistent symptoms. So I do have a cohort of patients who are clearly at least they've had COVID before, whether their symptoms are related. We hope that that's what the case is. So we do an initial evaluation on all of the patients. And because the symptoms are usually quite vague to start with, such as fatigue or muscle aches or even shortness of breath, we've done kind of a baseline testing of patients with pulmonary function tests and an echocardiogram and a full physical therapy evaluation. Our physical therapists are amazing with the evaluations that they do for these patients, and then a battery of blood tests to try and help to further understand what's going on with these patients. And then that's kind of our Recover Center clinic. And then based upon what patients' symptoms are and what we found on these initial studies, we refer patients to any number of specialists. We've got about 18 different specialties throughout the clinic who've raised their hands to say, we want to be the long COVID specialist here. So we have folks in cardiology and pulmonary and urology and neurology and neuropsych, and they have developed their own pathways so that once patients come to them, depending upon the patient's symptoms, then they'll send them through another set of either testing or get them into the treatment that they need. So at the Recover Center itself, we're really just kind of screening patients and trying to get them to the right providers that they need. But we hope that the information that we've gathered is robust enough to really set patients on a good path.
I wonder if you can share a patient's story to tell us a little bit about someone who has been through the experience.
So, I can think of one as a young college student who was having a lot of difficulties with some memory issues and certainly fatigue, but also a lot of kind of orthostatic symptoms. So when, standing up would get really tired and get really dizzy, and was just having a lot of difficulty returning back to normal daily functioning. One of the more important things that we can do from an intervention standpoint here is to get those patients to either our neurologists or our cardiologists who specialize in these orthostatic, or what's called POTS, postural orthostatic tachycardia syndrome patients. And POTS can be seen in other disease processes, but we're certainly starting to notice it more in our patients with long COVID. So for some reason, the virus has attacked what we call the autonomic nervous system in the body. So where normally I go from sitting to standing and my heart rate goes up a little bit and my blood vessels kind of tighten up a little bit so I don't drop my blood pressure. These patients aren't able to do that. So as they go from one position to sitting or standing, their blood pressure drops and they get dizzy and they get weak. So there are ways that we can treat that. But we have to identify it first. So this is part of what we need to do, is to get these patients, listen to their symptoms, try and understand what's causing them, get them to the right cardiologists, get further testing, and then be able to get them well on their way to treatment recovery.
Dr. Englund, I'm kind of puzzled about some of the things that your specialty colleagues are trying. So, for example, what are the cardiologists doing for, let's just say, irregular heart rhythms? Because I hear that AFib may be one of the possible complications. What are the neurologists doing about people who are complaining about brain fog? What are people doing to actually help people who feel dizzy when they stand up? We've heard things like eat more salt, drink less fluid, or drink more fluid. So if you have any sort of early tips that you can provide our listeners, and are there any support groups where people can go online to hear from other folks who are also considered long haulers?
Oh, absolutely. So each of these specialties kind of has developed their own algorithms and their own care paths for patients. So depending upon what patients are feeling, if patients are having these palpitations or feelings of their heart beating fast, we need to identify that. So we need to, oftentimes put on a patch that will help to understand what the heart rhythm is and diagnose AFib. And if it is, then certainly there are medications that we can convert them out of that atrial fibrillation, or if they're just having a high heart rate, that can slow down the heart rate and help with those symptoms. If your heart's beating 140 times a minute, you're just going to feel that, and that's going to make you feel anxious too. So bringing that heart rate down with medications can certainly help with a lot of the symptoms. As I've mentioned, the POTS syndrome that people can have, there are certainly medications that can be used to help treat those symptoms. You're absolutely right. Eating more salt does help. Also making sure that you're drinking plenty of water as well. But, taking a bottle of Gatorade, a couple of times a day and putting a little extra salt in that really does seem to help these patients. I also think that for those folks with these fatigue symptoms, pacing yourself and making sure that you are, again, not hitting days where you're overexerting yourself and then spending a couple of days where you're trying to recover. So finding this even keel of pacing yourself. Finding something like an exercise program that is where you're able to do it at your own pace. To be quite frank, I had COVID in May of last year. And
wait a minute.
Yeah.
Dr. Englund, are you a COVID survivor?
I am a COVID survivor. And I had COVID in end of May of last year and did not have any of the pulmonary symptoms, had a lot more of just the profound fatigue and a lot of the GI symptoms. And to be quite frank with you, I feel like I'm a long hauler as well, because I was still probably 2, 3, 4 months later taking naps on the floor of my office in the middle of the day because I just couldn't get through an entire day. But I'd close my door and lay on the floor and take a nap. And I think that also helped me to be able to understand. And this was early on. So, long COVID wasn't even really being discussed to any significant degree at that point. But, months later, I kind of realized what was going on and thinking, maybe we should look into this, because I don't think I did a good job of taking care of myself during those early months. But one of the things that did help me is I've been taking, I had been taking Taekwondo for a couple of years, and I got back into it. But my instructors were very understanding. And, I just took things at my own pace. And if I wasn't there for a week, they understood I was just having a bad week. But, even during the classes, I took it at my own pace. And I think that's really important, is to not try to jump back into what you were doing before too quickly.
And even with an ordinary virus like the flu, you may need to get back into your exercise program like Taekwondo a little bit more slowly. You can't necessarily pick up at exactly the same pace you were at, before you got sick.
Absolutely. I mean, there's purely just deconditioning, just from being out for several weeks and having been ill, overall. But just, I also think with this long COVID, it's people need to forgive themselves a little bit and give themselves more time. I found I was getting very frustrated with the fact that I couldn't do what I wanted to do before. And then eventually I was like, you know what? This is just where I'm at, and I'm gonna accept this, and I'll get back to where I want to be eventually. But for those people who are kind of type A personalities like me, it is difficult to accept, I think, the limitations that you need to allow yourself to have.
Dr. England, there's a fair amount of overlap between especially the fatigue that people are reporting as part of the long COVID experience and something that we have long called chronic fatigue
Yeah.
syndrome, or it has a fancy name, ME of some sort. Um, I'm wondering if there's anything that doctors have learned from helping people with chronic fatigue syndrome that can be applied to long COVID.
I think chronic fatigue syndrome has also had a lot of difficulty with being truly accepted as a true disease entity. I think when people list themselves as having chronic fatigue, there's, you can sometimes see eye rolling and, oh, come on, that kind of a response to it. And I do think that if there's any benefit of COVID and long COVID, it's to help us to understand that, okay, these patients have had something, and the long COVID patients, clearly have a defined entity as well. And there's going to be, I think, a significant overlap between those. Have we been able to identify a clear viral target that's been causing chronic fatigue syndrome? I think Epstein-Barr virus was at one point in time considered a potential etiology for that, and that kind of got negated in some studies. But there is truly something to this persistent inflammatory response that people's bodies have, whether it's post a viral illness, post a bacterial illness, whatever the etiology of it is. Some people just respond with this persistent inflammatory response. And I think if we really do a deeper dive into what the etiologies of chronic of long COVID are, we'll definitely be able to understand our patients with chronic fatigue much better.
Well, it seems to me, Dr. Englund, that this is an opportunity, especially for the clinician researchers, because, as you point out, chronic fatigue syndrome has been with us now for a couple of decades. And there has been a lot of eye rolling, like, oh, it's all in your head. I remember interviewing a woman who rode horseback, and she was incredibly healthy, and she ran for miles a day, and then one day she couldn't get off the couch, and it persisted for over a year, maybe longer, and nobody could really understand, well, what happened. Why have you gone from this healthy, rugged individual who can do almost anything to basically an invalid? And I think that, if we can unlock these secrets with long COVID syndrome and apply them to perhaps chronic fatigue syndrome and maybe even conditions like Lyme disease, because there are people who say, I got bitten by a tick, I had Lyme, I got treated, but here I am a year later and I still have brain fog and I can't get off the couch.
Absolutely. I think that is one of the other big challenges, and Lyme may very well fall into this same pattern as well, where more antibiotics aren't going to help. More antivirals aren't going to make long COVID go away. but what's the underlying pattern with this? And there is a lot of research really beginning to start. I know the NIH has put out a number of grants already to start to look at kind of the microbiologic level, of what's causing this. And there are some studies looking at the microbiome. And I know you recently did a story on the microbiome, but how that also can be impacting the recovery from COVID itself. So we need, while some of us are doing more of the clinical work to try and identify at the patient level how we can help patients get better, we need so much more research underlying as to, what causes the symptoms, who's more at risk for it, so we can prevent people from getting long COVID, and then ultimately what kind of, cellular level treatments will we be able to offer patients.
Dr. England, as we've mentioned before, you are the director of the Recover Clinic for long COVID patients at the Cleveland Clinic. How many such clinics are there at various institutions around the country? Is this a common thing that's being set up now, or is it still pretty unusual?
I would say that we're seeing more and more clinics pop up on a regular basis. I think when we look at, say, the United Kingdom, their National Health Service has really embraced long COVID, and they have opened up, I think their plans were for 40 long COVID clinics. There's certainly recognized clinics in all across Europe. And here in the United States, probably our forerunner for all of this was Mount Sinai. They were one of the first clinics to start this up in New York, and have done some incredible work there. But as you start to look across the country, we've got clinics in virtually every state. But when you look again at the numbers that we talked about, there's a tremendous need. I've limited, basically right now to Cleveland Clinic patients with a positive PCR test. So I've really put up some significant guardrails to try and control the number at this point. And I've got over 1,000 patients. So the more clinics that are opened, it's going to be so much more important to get more clinics open to better care for all these patients, across the country and frankly across the world.
Now, in the UK, they have a National Health Service, so I'm assuming that people who learn something about treating such patients are sharing it with everybody else in the country.
Yeah.
Is that happening at all in this country? I mean, our healthcare system is so fragmented and siloed. Are people at the Cleveland Clinic mentoring people in other places who want to learn how to take care of these patients?
Absolutely. I would say that certainly what we have seen coming out more frequently is articles are being able to be released more rapidly so that we're able to get information out sooner than they would have before. And there's a lot more meetings that we're finding online. The head of our sleep program just I'm not going to say, she virtually attended a national meeting talking about long COVID and sleep patterns, because insomnia is a really big problem for our patients as well. So I think there are wonderful opportunities for us to connect. And boy, I tell you, the virtual world has really made it so much easier for us to be able to do this. So I don't have to get on a plane and fly to San Diego to be able to talk to a limited number of people. We can do many more programs, and such as your program here, and getting this information out. But the Infectious Disease Society of America is putting out weekly information podcasts on information such as long COVID. So there's much more information out there. And I think we just have to make sure that clinicians are looking for it. And again, part of that goes to the initial acceptance of long COVID as a true entity.
Dr. England, I'd like to ask you a dark question.
Yikes.
And it has to do it has to do with money.
Yeah.
In the early days, I think, people didn't have to pay if they had to go to the hospital or if they had to be in the intensive care unit for a week or a month. And those bills could range into the hundreds of thousands, if not into the millions of dollars. But now that we have 40 million people who have had COVID, and anywhere from 10 to maybe 30 or 40% who are experiencing long COVID. And that's a lot of people.
Yeah.
Who's going to pay? How is the Cleveland Clinic dealing with billing? Are insurance companies paying for all of those specialists that you mentioned? What are we going to do about the cost?
I completely agree. I think that's one of the issues that we are going to find about long COVID is not only is it a challenge for patients to have these symptoms and feel miserable for a variety of ways for months on end, but they are going to be impacting the healthcare system and the cost of the healthcare system. And along with that, it's going to involve, the economic impact of that as well, with patients not being able to return to work, or at least not full-time work, and childcare issues if they're unable to really care for their children. So this is going to impact so many different aspects of finances across the entire country. To answer your question about what we're doing now is I have found that insurance companies thus far are paying for it. If patients don't have insurance, there is still federal finances available through their COVID relief programs so that we can get costs covered. I think part of what I'm trying to do with the Recover Clinic is quickly understand what patients' needs are and get them to the right people, as opposed to having them bounce around from primary care to one specialist who might not be the right person. So we're trying to streamline patients' care so that they do get to the most effective provider quickly. But, that does involve costs through the health system. So I don't think there's any good answer at this point in time. I certainly hope that our insurers continue to appreciate this as a clear disease entity and cover the costs of it. But I do think this needs to be part of a bigger national discussion on just overall financial costs of not just acute COVID, but the long COVID syndrome.
Do you have any advice for people who feel that they might have long hauler syndrome?
Yeah. So what I think people really need to do is to, understand that they have a real entity, and that even though, people around them may be saying, oh, come on, buckle down, just get back to work. Come on, just get up off the couch. You've got something that's real. And sometimes by overexerting yourself, you can make it worse. I mean, I often hear from patients that they may have a good day and they go out and they do what they think they can do and maybe even push themselves a little bit further. And then for the next day or two, they pay the price and their body is even more tired. So they can really get this cyclical kind of syndrome of doing a lot and then, like I said, paying the price for it for the next couple of days. So pace yourself and then talk to your provider, talk to your regular medical provider, your primary care doctor. And if you're not getting the answers that you want there, get online. Start making phone calls and see if you can find providers who are more in touch with the clinical syndrome and may be able to help you get into appropriate care. But again, understand that this is real, and that while we may not have a particular silver bullet to treat this with, a pill that we can make everything get better, you can get help that will help you to get better, at least start to get better.
Dr. Kristen Anglund, thank you ever so much for talking with us on the People's Pharmacy today.
What a pleasure. You guys were wonderful, and thank you so much for having me on.
You've been listening to Dr. Kristen Anglund, an infectious disease specialist. She leads the Cleveland Clinic's Recover Clinic for long COVID patients with lingering symptoms. Dr. Anglund is board certified in internal medicine with a subspecialty certification in infectious diseases by the American Board of Internal Medicine. She's the 2020-2021 president of the Academy of Medicine of Cleveland and Northern Ohio.
After the break, we turn to Dr. Bruce Patterson of IncelDX.
Dr. Patterson has identified a possible cause of long COVID.
His company looks at blood cells for diagnostic purposes and has identified an anomaly in long COVID patients.
When blood vessels react to these changes, the result can be fatigue, headache, brain fog, and other typical symptoms.
He and his colleagues have identified some drugs that can relieve the inflammation.
Are these medicines on the market, or is it just research?
We'll get the details on how doctors could help long COVID patients recover more quickly.
You're listening to The People's Pharmacy with Joe and Terry Graydon. This podcast is brought to you by the Verrazana Health Club. This comprehensive home testing service enables you to track crucial health markers of gut health, inflammation, metabolism, hormones, thyroid function, and many other organ systems. Regular testing can help detect health imbalances before they lead to sickness. Online at Verrazana, verisana.com/health-club. Get 50% off the first month with the discount code PEOPLE50. Welcome back to the People's Pharmacy. I'm Terry Graydon.
And I'm Joe Graydon.
The People's Pharmacy is brought to you in part by CocoVia, now offering its Cardio Health Powder with 500 milligrams of cocoflavanols. More information at cocovia.com.
And by Kaya Biotics, organic probiotic products made in Germany. Kaya biotics.com.
A lot of research groups are trying to understand what could be underlying the diverse symptoms of long COVID. One such group has been focusing on monocytes, a type of white blood cell. Is there a connection to the ongoing symptoms that long haulers report?
We turn now to Dr. Bruce Patterson. He is the CEO and founder of InCell-Dx, a single-cell diagnostic company. It's committed to advancing precision medicine based on an innovative technology platform that enables simultaneous cell classification and single-cell analysis of proteomic and genomic biomarkers. Dr. Patterson was formerly the medical director of diagnostic virology at Stanford University Hospitals and Clinics.
Welcome to the People's Pharmacy, Dr. Bruce Patterson.
Thank you. It's a pleasure to be here today.
Dr. Patterson, we've just talked to Dr. Kristen England, director of the Recover Clinic at the Cleveland Clinic. She herself is a COVID survivor who has had to deal with persistent symptoms.
Dr. Patterson, there's a lot of confusion about the underlying causes of these symptoms that can linger for months or possibly even longer. We understand that you've been seeking answers through your research. What can you tell us about the possible or probable causes of long COVID?
That's a great question that we started on in the summer of 2020 when we found that the immune system of patients with acute COVID was nowhere near normal, even though they were going home and surviving their acute illness. We then did immune profiles and used artificial intelligence to really tell us what is the difference between somebody who has acute COVID and what's the immune profile of somebody who has long COVID. And sure enough, they are completely different. So then we started to seek what the causes may be. And as we recently published, we really think the cause is vascular inflammation. And this vascular inflammation is caused by white blood cells that still have protein of the COVID virus or the SARS-CoV-2 virus, but they don't have the RNA. So the virus can't replicate, but the immune system is still recognizing the fact that there's COVID protein around, and those cells bind to blood vessels and cause inflammation, which accounts for the symptoms.
What do these white blood cells normally do?
It's actually part of their normal role to scavenge foreign antigens, either that are from the environment or from other pathogens, and present them to the immune system. And eventually those cells die off. But the cells that we found in particular, which are called non-classical monocytes, their role in the immune system is to patrol the blood vessels. And so they have a capability of, like bees going to honey, of being attracted to blood vessels. And therein lies the source of the inflammation that persists and causes a number of these, if not all, of the symptoms that we're seeing in long COVID.
Dr. Patterson, that brings up a really important issue, and that is, okay, we know that blood vessels are especially vulnerable to this virus, and that's why we've heard about things like strokes and myocarditis and all kinds of other things that affect those blood vessels. But we're also hearing about fatigue and headache and brain fog and hair loss and shortness of breath and loss of taste and loss of smell. And the list just seems to go on and on. How could all of those things be related to the mechanism that you're describing with regard to these monocytes reacting?
And that's what's truly amazing in the 10,000 patients that we have in our program and are in the process of treating. And that is, all of these symptoms start to become resolved when you block those two pathways that I mentioned. One of the hallmarks of these cells is that they have a propensity to travel all over the body, including through the blood-brain barrier and into the brain to cause vascular inflammation in the brain. And the fact is, what's very, very interesting in our last paper is that these cells are mobilized by exercise. And to a person, every long hauler has exercise intolerance. And it's because exercise mobilizes these cells, which carry COVID proteins, and those cells with the proteins go all over the body and cause localized inflammation. When you relieve the inflammation, what's amazing is that these diverse groups of symptoms go away. And that's what's been really remarkable and has given validation to the fact that when you relieve the inflammation, the vascular inflammation, this wide variety of symptoms tends to resolve, and including brain fog and ringing in the ears and shortness of breath and fatigue.
Well, Dr. Patterson, how do you relieve the inflammation?
Well, again, our whole program is built on treating the cause and not the symptoms. So to keep these monocytes from mobilizing all over the body, we use a class of drugs called CCR5 antagonists, which these cells express this molecule called CCR5. And like I said, like bees to honey, are attracted to areas where the inflammatory protein rantes is produced. And we block that with one class of drugs. And then we block these cells from binding to the blood vessels through another pathway with a fancy name called fractalkine by using statins, which are the cholesterol-lowering drugs. So we attack the cause, and we don't treat the symptoms with steroids or some of the other modalities that you see other physicians and clinics using throughout the United States.
Dr. Patterson, if you'll forgive me, I think all of our listeners have heard of statins. They're very popular drugs that are used to lower cholesterol and reduce the risk of cardiovascular disease. But I would say that CCR5 antagonist is the kind of name only a pharmacologist could love. And even Joe isn't jumping in with a CCR5 antagonist. So please tell me, what is that?
Oh, that's a great question. I started about 30 years ago looking at CCR5 because CCR5 was a co-receptor for HIV. And so by blocking CCR5, you could prevent HIV from infecting T cells and monocytes and actually basically prolonging the lifespan in HIV-infected individuals. Well, along the way, they found that CCR5 was intimately involved in the immune system, both the adaptive immune system and the innate immune system, which is involved in active COVID. And it does that by controlling the movement of cells. it's like it's like the quarterback of the immune system telling immune cells where to go to sites of inflammation. And so it's an immune modulator, and it's not an immunosuppressive. So it doesn't make you susceptible to other infections, but it allows you to determine how to control the movement of immune cells. And it actually prevents some cells like macrophages from making all the cytokines that contribute to the cytokine storm. So it has a multitude of effects in the immune system, and we're taking advantage of the immune system to treat both long haulers, and now we're getting back to using these drugs in the context of acute infection, because it's also involved in acute infection, as we showed in the spring of 2020.
So, Dr. Patterson, inquiring minds, and I know that there are a lot of them, both health professionals and patients and laymen, want to know, are there any CCR5 antagonists on the market? In other words, do you actually have a drug that already exists that does this, or is this an investigational new drug that the FDA has allowed you to use in these situations as an experiment?
That's a great question. And the fact is, Maraviroc, which is a CCR5 antagonist, has been approved for use in HIV. It's shown in a large study to be safe in a 5-year follow-up to HIV patients. And it's also been shown to be safe in the pediatric population. And we've been using that as part of a cocktail with statins to improve the lives of long COVID. And it's been very, very succesful.
Now, before you go any further, please spell the name of this anti-HIV drug, and does it have a brand name as well as a generic name?
Great pharmacologic question. It's spelled Maraviroc, and its brand name is Selzentry, Selzentry, or TRI in the EU, where we're expanding our program to next week.
So this is a drug that is on the market, FDA approved for the treatment of HIV.
Correct.
And what you've done is repurposed this drug, this CCR5 antagonist, together with statins. Do you have any particular favorite statin that you're using?
Yeah, we use Prevestatin, and we use it because it has a lower side effect profile than, say, atorvastatin, which can cause lower body weakness and maybe even some cognitive changes. The last thing we wanted to do with long haulers is add to their list of ailments. So we like the Prevestatin as our statin of choice.
So you're using these two drugs, and where would a physician who wanted to see your protocol go to find out how you're using these two drugs?
Yeah, the best way is to go to www.covidlonghaulers.com, which is part of IncellDX Inc., the company which I run. And they can find out all the information they need on the drugs, the protocol, the process that we use. We don't actually prescribe the drugs, but we do use precision medicine. So we developed a novel AI-based assay that we have agreements with several laboratories in the United States, and now a very large laboratory called SynLab in the EU that will cover the EU, UK, Mexico, and Latin America to run this assay and provide the precision medicine diagnostics that we need to determine exactly how to treat these individuals.
Dr. Patterson, you have identified immunologic markers in blood. And I guess there are a lot of health professionals out there who perhaps have forgotten their molecular biology and their immunology. And so they may not be familiar with PASC, post-acute sequelae of COVID-19. and how the immune system reacts. I'd be interested in how you would explain to them why they need to think differently about how they're treating long haulers, number one. And then number two, I'd like you to dig into the implications of your work for other hard-to-treat conditions like chronic fatigue syndrome, Epstein-Barr virus, CMV, HIV, all of these conditions that may have some similarities to long COVID.
Wow, that's a big question, and really to start, it was interesting when we identified this unique pattern or signature, if you will, in PASC, that there were certain markers that were very, very different than acute COVID, mostly the type, what we call the type 2 cytokines, and the fact that PASC individuals actually look like they have a somewhat appropriate immune response against what would be a virus, as opposed to, when we were first looking at acute COVID and the innate immune system was engaged, which is a very non-specific arm of your immune system, because frankly, this was an emerging pathogen that nobody had ever seen before, and our bodies hadn't seen it before. So we didn't have in our repertoire of immune responses anything that was directed towards SARS-CoV-2. So, it was a very different set of immunologic markers that were all derived from the fact that we probably started with over 150 biomarkers in early COVID, which we started in collaboration with groups over in China in mid-January. And then we eventually narrowed down to 14 markers that really identified what was going on and what was different about acute COVID from PASC. And really the hallmarks of PASC were that there was vascular inflammation markers, VEGF, soluble CD40 ligand. There was macrophage activation markers like TNF alpha and some interleukin 6. But what was really interesting was that these two proteins, interleukin 2 and interferon gamma, which were the numerator on our long hauler index, were elevated. And then after digging in the literature, those two cytokines are actually elevated when non-classical monocytes bind to vascular endothelium and cause inflammation. So it was very satisfying from two very different directions to see that the two cytokines that were driving the computer analysis were actually, in fact, part of the mechanism of these cells, which carry the S1 protein binding to the blood vessels and causing inflammation.
So now that you've identified this very fascinating pathway, how does it have broader implications for these hard-to-treat conditions like chronic fatigue or EBV or CMV or HIV?
Right. All of those are very, very different. So you have to take that into account. But the ones with the most similarity, I would say, is post-Lyme. For instance, the cell wall of the Lyme bacteria, Borrelia burgdorferi, for the most part, persists for long periods of time. And actually, there is evidence of those proteins in the same monocyte or white blood cell subpopulation that we identified in long COVID. And of course, as I just suggested, that those cells have the capabilities of migrating all through the body and causing inflammation. And that's why a lot of the symptoms in post-Lyme resemble the symptoms in post-COVID. And I'll tell you right now, we've now treated, I would say, over 30 post-Lyme patients with the same regimen as we're treating long COVID, and they are responding for the first time in years. The stories are heartwarming because of the fact that they've responded by blocking the same pathways that we're blocking with drugs in long COVID. And we're just starting to look at chronic fatigue syndrome, which could be a little bit different because of the involvement of truly latent viruses, like you mentioned, EBV, CMV, herpes simplex, varicella. So herpes family viruses all have a true latent phase where they can actually reactivate, in the course of your lifetime, as opposed to RNA viruses like SARS-CoV-2, which tend not to have a long persistent phase where they can reactivate or even replicate, for that matter.
Dr. Patterson, would you be willing to share the protocol with the health professionals who will be listening to this extra part of our broadcast?
Well, what's great is I'm actually speaking at the International COVID Summit in Rome, September 11th to September 14th, where we will be laying out our protocol. We will also be showing the pathway that the protocol addresses. So I think kind of visually putting together what the protocol is with slides that show exactly what we're inhibiting is something that really pulls everything together, as opposed to just describing what the protocol is, without the context. But we're probably a week away from describing our success rates and response rates. The great thing is, in various reports from CBS News and various newspaper reports and online reports, a lot of our patients are speaking up and talking about their journeys and talking about, their response and how great they're feeling now after being, bedridden for so many months. And that is really heartwarming to me to hear those testimonials coming out in the press. And then, of course, we're actively writing up everything for publication that we're doing right now. So,
is this a chronic treatment, or after a certain period of time, patients can wean off the medications?
That's a great question. We've seen the response somewhere between typically 4 to 8 weeks. And then what we do is, because they have exercise intolerance, phase 2 of our program is really to start their exercise back up again while they're on medication, see how they respond. And then if they have no relapses or increase in symptoms, then we withdraw the medications, and they're left to move on with their lives at a level that approaches their pre-COVID levels. And I think that's been really reassuring. In fact, I've had a couple of patients on telemedicine in the last few days who say, now what do? I feel good. I don't have any appointments. I don't, what's the plan for me? And I said, go live your life, and again, that's a message that just is so heartwarming for me to see patients who 8 weeks before couldn't get out of bed and couldn't go about their activities of daily living, now all of a sudden, living life again.
Dr. Patterson, you've written about a patient whose doctor actually suggested psychiatric treatment rather than offering any kind of medical treatment for her long-haul symptoms. But your analysis was able to identify some immunologic markers in her blood. Can you tell us a little bit more about that case without betraying any confidence, and give us the message for physicians who are not familiar with PASC?
Well, again, I can discuss that case because now that case is, at least in our hands, probably 1,500 or 2,000 different cases that had this same experience when contacting the medical community, especially last summer and last fall when we started out having identified the immunologic abnormalities in PASC and started to think about treatment strategies. These were all patients who had gone to their primary care physicians and were sent to psychiatrists who said they had PTSD or post-COVID anxiety. And I'll tell you, just by using AI and machine learning to determine that PASC was a unique and different immunologic entity than acute COVID, I would say we won 50% of the battle on that day because we were able to tell these now millions of people, 30% of everyone who has COVID, we were able to tell them, you have something and you have something real. I can't tell you what that meant to them just, without any other information about treatment or what we were going to do or discovering the mechanism like we have now, but just telling them that, you know what, you're sick. Your immune system not only hasn't recovered from COVID, but it's now morphed into an immune profile that is a unique amongst itself and unique among long haulers. Although now we're finding a very similar immune profile in post-Lyme, in the post-vaccination individuals who have long COVID symptoms 3 and 4 months out. We're seeing these patterns emerging that we really think have very similar pathways and very similar mechanisms. And we are now the recipients of one of the first single molecule proteomic devices to start looking at foreign proteins in these different subpopulations of monocytes that may be causing these wide variety of diseases that may have been missed because we were only looking for nucleic acids, RNA and DNA of the pathogens, and we weren't looking for the proteins.
Dr. Bruce Patterson, thank you very much for discussing this important topic with us on the People's Pharmacy.
It's a pleasure. Thank you so much for your time.
You've been listening to Dr. Bruce Patterson, CEO and founder of InCell DX. This single-cell diagnostic company offers transformative diagnostic and prognostic clinical patient information based on an innovative technology platform that enables simultaneous cell classification and single-cell analysis of proteomic and genomic biomarkers. Dr. Patterson was formerly the medical director of diagnostic virology at Stanford University Hospitals and Clinics.
Dr. Patterson's research is still preliminary and needs to be confirmed by other research groups. You will find links to his publications at our website, peoplespharmacy.com.
Lynn Siegel produced today's show. Al Wodarski engineered. Dave Graydon edits our interviews. B.J. Liederman composed our theme music.
This show is a co-production of North Carolina Public Radio WUNC with the People's Pharmacy.
The People's Pharmacy is brought to you in part by Verizana, an analytical laboratory providing home health tests for hormones, gut health, and the microbiome. Online at verisana.com.
And by CocoVia, the maker of high-potency cocoflavanol supplements that support cognitive and cardiovascular health. More information at cocovia.com.
And by Kaya Biotics, probiotic products made in Germany from certified organic ingredients. KAYA Biotics.com.
Today's show is number 1273. You can find it online at peoplespharmacy.com. You can subscribe to our podcast through your favorite podcast provider. We post the show on our website on Monday morning. This week's podcast contains additional information that wouldn't fit in the broadcast today.
If you'd like to make a comment about this show, look for the post on our website, peoplespharmacy.com. Again, it's show 1273.
At our website, you can sign up for our free online newsletter to get the latest news about COVID-19 and other important health stories. By subscribing to our newsletter, you'll also have regular access to our weekly podcast and find out ahead of time which topics we'll be covering. In Durham, North Carolina, I'm Joe Graydon.
And I'm Terry Graydon. Thank you for listening. Please join us again next week.